If you haven't met me yet, my name's Anna. I'm a longtime Arcadian, have a chance to work with many of our customers. I oversee some of our more advanced and complex relationships with health plans, health systems, and the government side of the healthcare spectrum, as well as our customer enablement teams. And I wanted to spend a few minutes today talking about patient stratification. Why do we do it? How do we do it? Tips and tricks. So let's start on the basics. When we think about patient stratification, a lot of this is focused around understanding where a patient is in disease progression, because that's really going to impact the right way for us to engage with the patient and understand them and how we can best help them. So in our most core and basic stratification model, some 80% of the population is low risk. These are the patients where really all you need to do is make sure that we're getting the right preventive care in place and keeping the patient on track. From there, we move into rising risk and high risk, where rising risk are typically your most impactable patients. These are the folks that are dipping their toe into more advanced healthcare challenges. They're starting to develop chronic conditions. They may have shown up in the emergency room once or twice. There's a real opportunity here to divert the patient, to make sure that they're moving in the right direction. And finally, high risk. These are the areas where the patient has a truly advanced condition. There's a meaningful volume of care that the patient needs to be getting. And in many cases, unless this patient has also picked up their own MD along the way, this is where there's a real gap, oftentimes, between what the patient knows and everything the patient needs to be doing. So obviously, those hit three really different areas. But part of the trick here is knowing that those cohorts are just the start. Not all high-risk patients, not all low-risk patients need to be approached the same way. So what we'll do today is spend just a couple minutes on each of these, talking through some of the opportunities to use data to better understand your patients. We start on the low risk. This is the young, healthy, invincible. Honestly, it's probably a lot of the folks around this booth, including some of you. These are the patients where you don't necessarily need care management yet. You don't need to be engaging the patient in a ton of specialist care, so this doesn't have to be the hard stuff. But this is where it's really important to make sure that the patient is checking the boxes on a handful of things, that they're engaged in primary care, because that relationship is going to be critical further down the line. Make sure that they're getting cancer screenings, making sure that kids are getting all of those immunizations. Some of the pieces that are easy to miss, because not every patient lives in the world of HEDIS measures and knows when to start their colonoscopies and mammograms and how many years between each colonoscopy depending on your results, right? This is the stuff that like a handful of us know inside and out, but when we're talking to our friends, you realize that it's going right over their heads. A few best practices here. A lot of this is education on the importance of primary care. It's just getting the message out there that even though you feel great doesn't mean you don't need to see the inside of an exam room. It's also where you've got a real opportunity to use technology. Purely from a demographic standpoint, these are the patients that are a lot more likely to engage if they know that they don't have to drive to the doctor's office, sit in the waiting room, and wonder what time their appointment is going to happen. In many cases, this is the engagement that you can knock out with a 15 or 20-minute virtual visit. And in many cases, they're going to be open to it and engaged in it and not necessarily have a good reason to come in. The final piece that I'll throw out there is that this is a great time to start thinking about social determinants of health. Because as you think about the higher end of the low risk, you start getting into patients who really should be coming in, like for whom it's really a little bit more important that they make it into that annual visit and that it's actually annual and not like mine, which is annual in theory. But this is where you have a chance to start thinking about why that patient isn't coming in. Because if you're just sending out email blasts telling them that it's important to go schedule an appointment and they don't speak English, they don't have transportation, it can start to feel for them like healthcare isn't designed for them. Like there's a barrier there and it's not meant for them to cross, because if it was meant to be, surely there'd be some sign, there'd be some guide, there'd be someone talking to them about what to do if you can't afford your copay, about what to do if you don't know how to get to the doctor's office. These are all the areas where patients aren't always going to reach out proactively and ask. So getting that information out there can pose a ton of value in cementing that bond. Which leads us right into our high and rising risk. This is where understanding the patient, understanding their care gaps, their care history, their barriers, their opportunities, is critically important for carving out the right cohorts within this. This is where you're going to have a lot of patients for whom, again, getting into those primary care visits is a really, really key for managing their care and making sure that there's a quarterback that's on point for talking them through why we think that they should have a follow-up to that ED visit. Talking them through how to set up that appointment with an endocrinologist, and then following up to make sure that they actually do. This is one of the places where data and interoperability become critical, because that next step for the patient, that next appointment, might not be in their own four walls. So having a closed loop referral system, making sure that we know that they never actually set up the appointment with a specialist, and following up with them to see, again, what broke down. Following up on the lab work that got done that might have a red flag in it is really key. We talked earlier about that bond with the primary care physicians. One of the really neat tools that you can have here is thinking about who is the PCP. Is this somebody that's been bobbing around a couple of practices? Is it somebody that is assigned to a primary care physician, but they've been seeing the NP for the past couple of visits, and that's where they tend to get a really good conversation going. That's where they open up. Keeping that in mind, thinking about how to make sure that this messaging is coming from someone they trust can be really key through this journey. A couple of the other big ones, following up on the EDs, following up on admits and discharges. This is, again, an area where you can streamline a lot of this through automated outreach, grabbing down the ADT message and immediately shooting out a text to the patient, or using that ADT to trigger a task for a care manager to reach out, make sure that patient gets scheduled, so that the request that they set up an appointment doesn't just get lost in the pile of mail that's sitting on their desk when they get back to the hospital or from the hospital. And finally, when we think about the chronic conditions, when we think about periods like high-risk maternity, it's an opportunity, again, to educate the patient. It's so often that we think of the patient's gaps as a checklist, something to blow through in an appointment, something to fire off a bunch of orders for and say, check the box, meaningful use-wise, we're all set, we're going to show up in green on the report. But again, often the key here is engaging the patient in their own care. This is where care management programs can be hugely valuable, and where many of the organizations that we work with have spun up really targeted and customized programs and identified patient identification and enrollment criteria around that. Developed scripts for enrolling the patient, making sure they understand the value of the program to them, making sure that they can really trust whoever it is they're going to be working with. So as we think about narrowing in, as we think about going from this is a rising risk patient to understanding who's the right person to reach out to this patient, how do they do it, what do they say? This is where data comes in. This is what's really exciting to me, because this is the opportunity to use the data that we're already logging in order to identify the right path to the patient. Just a few examples of the models that can get sliced together here. Quality of care. Again, this is the basics, right? It's what we try to do on a day-to-day basis, but it's using quality measures to identify where a patient either already has a care gap or will have one if they don't get in for that wellness visit and get a really thorough workup. Again, thinking about social drivers of health, and I love the terminology of drivers here because they're not firm determinants. They're something that we can partner with the patient to overcome. So thinking about the patient's individual social needs, where is the right place in the continuum of care to capture that? Again, making sure that somebody the patient trusts is asking them these questions. But also thinking about how we can leverage broader data. One of my favorites here is the American City Survey. It's the Healthy Places Index in California. It's a number of these tools that can get down to a city block level. Identify the key challenges, identify the demographic outlay of that area in order to understand what a patient is likely to be facing even if it's not based on an actual assessment that's done with them. And what I love about this is it's a great way to get an initial view around that patient when you haven't had them come in the door yet. Cost and utilization. Again, this one's pretty obvious, but so many organizations use this purely retrospectively. The other question here becomes, when somebody's been in the ED 2, 3, 4 times, we should start to ask, are they spending more time in the ED than they are in their PCP's office? It's a really, really obvious area for engagement. Thinking about a number of potential models here, this is where some of the impact models can really come into place. When we talk about impact models, we're thinking about looking forward. Not just has the patient had a hard time historically, which is what cost and utilization will give us, but really starting to dig into, does this patient look like the patients who've had 3 ED visits looked a year ago? Is this somebody who's likely to benefit? When we look at a high-cost patient, oftentimes our highest cost patients are not going to be highly impactable through your traditional care management programs. There's a lot of support that they need. But if someone's getting into that 200, 300K range of cost because they've had an expensive and intensive surgery, because they have high-stage cancer, that's a different set of things that you can do than somebody that's starting up, that's starting to rev up their costs. They're a lower cost, but they're also at a place where there's a much greater opportunity to change their journey and to make a much greater impact. A few really good ways that we've seen some of this get combined. Behavioral health impact score. For me, one of the greatest advances that we've made as a healthcare system over the past decade or so has been starting to integrate behavioral health into physical health. There are still so many areas, particularly in areas like Medicaid, that treat behavioral health as something to the side, something that happens over there in that booth. And if somebody's depression tips over, if somebody has a particular episode, well, that needs specialized treatment, so they're going to get treated over there, and somebody over here is going to be dealing with their diabetes as though the two are completely unrelated. It's one of the areas where compliance can get hairiest because we want to think about privacy. We have to think about the patient's privacy. Mental health conditions shouldn't be something that gets blasted to anybody that walks past the patient. But at the same time, it's not realistic to think that a care manager who deals with somebody's physical health can do so effectively without understanding that there are, again, very meaningful barriers to care that are likely exacerbating the patient's condition by keeping them from engaging effectively. We've talked about social drivers of health. Many organizations use registries where they identify these patients and then line that up against gaps in care. Identify patients with a number of gaps in care as well as a barrier to transportation, and do a mailer or do some outreach around other ways that you can get to the office, around partnerships with services like Uber and Lyft, where the parent organization can often help subsidize the cost of making sure that the patient gets that care, because it's that important, particularly in value-based care contracts, to get the patient in the door. High-risk maternity is another one, and I love flagging this because it's one of the greatest opportunities for real-time data. Because if you're running off of claims, then knowing that this patient had a high-risk pregnancy 6 months ago because of claims lag doesn't actually help you that much. But knowing that a primary care physician saw them and there were early markers of risk can be really key in, again, engaging that patient 4, 5, 6 months into the pregnancy, making sure that they get the right care through that pregnancy for themselves and their child. So to wrap, a few things that I want to call out. The real opportunity here is around harnessing that data. And that doesn't mean that you have to have all the data in the world. It means that you've got to start working with what you have to understand the pockets of the population that need really targeted engagement, and start working with that as you continue to build out the data asset. Those cohorts need to be targeted and actionable. When you're building out a cohort, it's not about what they experienced in the past. It's not about one metric like cost or an HCC score. And HCC scores are great for what they're designed to do, which is risk adjustment. Where they fail is they just tell you that someone's going to be expensive next year, so plan accordingly. They don't tell you how to engage with the patient, which is where all those other models come in. And finally, think through the barriers of care. It's easy for us to sit behind laptops or in exam rooms and think about the fact that somebody should be doing all these things, and we just have to tell them. We just have to send them that memo, that list, that text message, that list of alerts in MyChart that says, here's all the things that you got to do. But when patients don't engage with that right away, the question becomes why? And that's one of the places where there's so much exciting opportunity to use the data in order to start to engage the patient until you get them in and have that conversation.